hopefully everybody can see and hear me. I'm going to see if this works. Good. Am I clever? Okay, so as she said, I'm Mike Silverman. I'll be lecturing today on EKGs. This is an intro. When I do EKGs for our residents, it is 6+ hours of lecture. So realistically, that's not something we can do today. What I'm going to do is kind of give the basics and add some potpourri of different things we look out for, some of the more common stuff and how we look out for it. Please let me know or stop us if I'm going too fast or there's any trouble with the lecture. So again, when we're looking at EKGs, we're looking at the electrical activity of the heart starting in the right atrium and going across and down through the myocardium. So that's what we're looking for. It's electrical activity, which then translates into actual pump function. Okay, so when you're looking at the EKG, we need to look at some definitions. So when we look at definitions, I just want to make sure we're hiding the floating screens. Okay, we're looking at the different waves. So everybody's talking in the same language. The first wave you see is the first bump is what we call the P wave. That is the electrical activity of the atrium, followed by the QRS complex, which is the first deflection after the P wave. A Q wave actually doesn't occur in most of the leads. So it's oftentimes the first deflection is upwards, would be the R wave. And then the second downward deflection would be the S wave, which would be here, but just to make it easier, I moved it over here. And then the T wave is the last deflection. The QRS complex is the depolarization of the ventricles. And the T wave is actually when the ventricles are repolarized. We also have to know intervals because we look at those to look for abnormalities. So the PR interval, which is the beginning of the P wave to the beginning of the QRS complex, is measured that way. You need to understand what the boxes mean. So there's horizontal and vertical boxes. And as you look from the EKG, there's the smaller boxes, and then there's bigger boxes, which are 5 small boxes in width and height. What the definition of the boxes are for the horizontal or the width, the boxes are, the small boxes equal 0.04 seconds or 40 milliseconds. The bigger boxes are 200 milliseconds or 0.2 seconds, okay? The normal PR interval, which we just talked about, is less than 5 boxes, which is 200 milliseconds or 0.2 seconds. And the normal QRS complex, which is the, should be less than 120 milliseconds or 3 small boxes. Those are important numbers to remember. So we also look at the QT, which is the beginning of that QRS complex to the end of the T wave, unlike the PR, which is to the beginning. This is to the end of the T wave. And that's an important thing to measure because as the QT interval elongates, what you'll find is you're at increased risk of having something that we call Q on T phenomenon, which can place patients at risk of going into sudden arrhythmias such as ventricular tachycardia or ventricular fibrillation. Although there's formulas to do it yourself, the QT corrected, which is what we look at, is the QT over the square root of the beginning of the R to the beginning of the next R. That only actually works in normal heart rates. If it's too fast or too slow, it doesn't work. But fortunately, there are a lot of online programs. I like MDcalc, which is an easy way. All you have to put in is the heart rate and the actual QT interval, and it will give you the QT corrected. It's important to know QT corrected is slightly different for men and women. 440 milliseconds is the upper limit all for men versus 460 for women. But we start seeing that Q on T phenomenon be at higher risk once it gets above 500 milliseconds. Again, things that can increase your risk for a prolonged QT are mostly electrolyte abnormalities, and drugs are the most common causes. Typically low potassium, low magnesium, low calcium can do it. If you're hypothermic, you can get it. Other things that can cause it are congenital long QT, which is something you're born with, or there's a lot of drugs that can cause prolonged QT. Okay. The next wave you want to look at is the ST segment, which is the end of the QRS complex, as I said, to the T wave. We look at that for signs of acute myocardial ischemia or heart attacks. And the best place to look at elevations or depressions in the ST segment, because they can be angled up or down, is at the beginning of the ST segment, which is called the J wave, J point. Okay, and when we're looking at up and down, or the vertical sections, where we talk about one small box equals 1 millimeter. So if the J point is above the end of the QRS complex by 1 millimeter, one small box, we'd say it's 1 millimeter elevations. If it's below, we would say 1 millimeter ST depression. Okay, this is important to know. Although when you look at an EKG, on the top of it, oftentimes it will give you the rates and the rhythms. It's important to know what they are yourself, because if they're irregular, they cannot be accurate. Sometimes if the T wave is too enlarged, it can be inaccurate. So those are reasons you might not want to look at those, okay? It's important to know from one box, you can estimate rates to the next QRS complex. These are the numbers I would memorize. One box is 300 beats per minute, two boxes 150, three is 100, it goes down, 4 is 75, 5 is 60, 6 is 50, and then it's in the low 40s. 43 is the exact number, but if you just realize it's low 40s, anything lower than 40 is concerning. So that's where I look at it and say, oh no, I gotta go get up and see this patient immediately. Okay, we're gonna talk a little about different causes of slow rhythms and rates and how to diagnose them. So there's blocks. There's 3 different types of blocks: first degree, second degree, and third degree. And then there's subtypes. A first degree block is when the beginning of the PRS complex, the P wave to the QRS complex, is greater than 200 milliseconds, or 5 small boxes. So it would be from the P wave beginning to the QRS. As you can see, this is almost 10. So this would be about 400 milliseconds. And it's consistent. Every P wave should be approximately the same to the QRS. As you can see here, it should be consistent. It should happen everywhere. This one, actually, the P wave is embedded in the T wave. So you may want to look at that. So here's an example of a block. This is not a first degree block. You see there's a P wave and a QRS complex, then another P wave and a QRS complex, and a P wave and a QRS complex, a P wave and a QRS complex, and then P wave, and then nothing. So it's what we call a drop beat, and then you get the next P wave. You lose the QRS complex. So that is a second degree block where you get inconsistent drops in QRS complexes. And there's 2 types. There's Mobitz type 1, which is also called Wenckebach, or Mobitz type 2. So for Mobitz type 1, what you'll see is the PR interval will slowly get longer. It can be subtle until you get the drop beat. And if you measure this, it's 1, 2, 3, 4, 5, 6 boxes. But by the time you get to here, it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 boxes, and then it drops. So this is something called Mobitz type 1, or Wenckebach is the other name for it. It's a second degree heart block. You see progressive PR prolongation till you drop one, and they are dropped or intermittently conducted. The other name for it's Wenckebach. Generally, this is a rhythm that in the short term is not dangerous or benign, but over time it can be dangerous. Next steps: if it's asymptomatic, we just watch it. If they have symptoms, you can try atropine to speed up the heart rate. If it gets to be symptomatic persistently, patients end up with pacemakers in the long term. You can use pressors in the short term. Okay, here's another block. You see there's a P wave and nothing. P wave QRS, P wave QRS, P wave QRS, P wave nothing, P wave QRS. So this is also a first degree block because it's intermittently conducted. Hey, Barney, your camera's on so we can see everything you're doing back there. So as you can see, it's dropped. But in the difference between this, the PR complexes on the beats that are conducted are all the same length. So this is actually what we call Mobitz type 2 or second degree block type 2. These are a little more serious because they can suddenly deteriorate to third degree block. So these patients need to be watched and usually get pacemakers acutely. So third degree blocks, that's when there's an absence of the conduction between the P waves and the QRS complexes. They're usually junctional or ventricular escape rhythms, which means they're electrical activity that's being started in the AV node with that versus the SA node, which is the normal place that it gets conducted. The most common reason we see those in real life is medication effect, but over time, if people with conduction abnormalities could present that way, or you can get it from ischemia or sudden heart attacks. Or acutely, you can try atropine if it's a narrow QRS complex. If it's wide, we try to avoid it. And then a pacemaker is the best thing for that. So this is an example of a patient with a third degree block. You see a P wave at a QRS complex, P wave QRS complex, P wave QRS complex, P wave here, P wave here. So the challenging with this, it can look like other blocks, but when you look at the rhythm strip, there's actually P waves that are going randomly that aren't attached to QRS complexes. So the QRS complexes are constant at the same rate versus the P waves, which are at different rates, which are at their own rate. So they are going independently of each other. So you're going P to P to P to P, and then you're going QRS to QRS to QRS, and they're at their own constant rates. So the QRS complex, for example, is going at 300, 150, 175, 60, about 50 beats per minute, but the P waves are actually going at 300, 150, about 100 beats per minute. So they're going totally independent of each other. Okay, that's third degree block. Sometimes you'll hear the term AV dissociation and third degree block used interchangeably. They are slightly different. Third degree block is a subset of AV dissociation. There are other causes of AV dissociation, junctional escape rhythms, ventricular tachycardia are a few examples of those. Okay. Another reason you might, what I call the slow rhythms or prolonged QTs are, as we mentioned, the QT you could measure and get the corrected QT, but a quick way at looking at QT, if the beginning of the Q wave, at the end of the Q wave to the end of the T wave is longer than half the R wave to the next R wave, that's a rough estimate that it's probably prolonged. So I oftentimes use that in practice when I'm handed a lot of EKGs over the day. The most common cause of prolonged QT is due to drugs or electrolytes. As I said, congenital, it can happen, it's when you're born with it. The biggest risk, as I said, with prolonged QT is the risk of getting a QNT phenomenon, which causes Torsade's dependent, which is a type of ventricular tachycardia. So this is an example. Patient's heart rate is 80. The actual QT is 440, but when you correct the QT, it's over 500. So this patient could be at higher risk for arrhythmias. Okay. If we think it's congenital, oftentimes you can use beta blockers to slow the heart rate down to decrease the risk of QNT and AICD if they do go into ventricular tachycardia, or if it's acquired secondary to medicines or drugs, you'd stop the drugs, or you, if it's electrolytes, you would replace them. Okay. The other thing, when you're looking at QRS, the EKG, you want to describe axes. Okay. So axes is basically how the electrical activity of the heart runs. Normally, as I said, it runs from the sinus rhythm across and down the myocardium. So it generally, in a normal sized heart with normal electrical activity, it's running in this direction, and we consider that normal axis. Okay. The leads that you put on the heart the limb leads, not the chest leads, help you determine access because they will determine where the leads are. So that's right arm, left arm, feet, and then the leads 1, 2, and 3. And this is normally, if it's positive, which way the axis is, the electrical activity runs. So by looking at the different, hold on, the different leads in the limb leads, you can determine axis. So when you're looking at that, you're looking, normal axis is somewhere between 0 to 90, or in some people feel it's up to -30 in terms of normal axis. And when we're looking at that, we're looking at two leads, either one in AVF, if you're looking for 0 to -90, to 90, or 1 and 2 if you're looking at 0 to -30. If it's upright in 1 and upright in AVF, it's normal axis. If it's down in either of these, it's either right or left axis. The best way to remember it, if it's down in 1, it's going to be right axis. I remember that because it's right next to AVR, which is on the right. If it's down in AVF or 2, it's going to be left axis, and they're next to those. That's how, when I was a medical student, I would remember it. Okay, that's axis. As I said, normally the electrical activity of the heart on the right goes down from the atrium through the ventricles. If one side's going slower than the other because there's conduction abnormalities, you can have blocks. Classically, you'll hear people describe right and left bundle branch blocks. When we look for right and left bundle branch blocks, the electrical activity on that side of the heart is going slower than the activity on the other heart. So a right bundle branch block, the right atrium and ventricle, the electrical activity are slower than the left. And it's actually the ventricle. That's why you see in the QRS complex. And that widens the QRS complex because you have electrical activities going at different times. That's the explanation. To find the right bundle branch block on an EKG, you look at V1 and V2. You should have a prolonged QRS complex. That's where it's greater than 3 little boxes or 120 milliseconds. And for right, you'll get that RSR prime, or some people call it an M-shaped complex in V1 and V2. So it has to be greater than 3 small boxes, and we'll create that M-shaped complex. What causes it? So if your right heart expands, if the electrical activity in the right heart is abnormal because of degenerative problems, or if you have inflammation like myocarditis, or enlargement like a cardiomyopathy, or a PE, which will cause stress on the right side of your heart because the blood flow from the going to the right side of your heart gets backed up, those can also cause a right bundle branch block. Left bundle branch block is a little harder, at least it was for me when I was a medical student and early in my residency, to pick up. And here you're looking for a different pattern. Again, the QRS complex has to be widened, greater than 3 boxes, and you're looking for a S wave in V1, which is just one big upward complex, a broad R wave in V1, if you have one, which is kind of this thing, V5, V6, you see how it's broadened out. And you get this typical slight R wave and big S wave in V1. Sorry, and broad R wave and big S wave. So there's the R, little baby R wave. So this is not a Q wave because the first deflection's upwards. Okay, so that causes can be similar: dilated cardiomyopathy, hypertension, coronary artery disease, or ischemia, heart attacks can cause it too. Okay, so now we're going to talk about fast rhythms. So fast rhythms can be one of the more challenging things for us to determine in the emergency department. I'm going to teach you quick ways to kind of break it up into 4 types of fast rhythms and to determine which ones they are. Okay, so the 4 types I use are, you want to look to see if the rhythm is regular or irregular, and if the QRS complex is narrow or wide. So if you break them up into regular and narrow, there's only 3 things they tend to be. It's just a simple sinus tachycardia, something called supraventricular tachycardia or a rapid aflutter. If they're irregular and narrow, it's going to be either atrial fibrillation, atrial flutter with a variable conduction, or a slow irregular atrial flutter, or a multifocal atrial tachycardia. Wide complexes are only going to be three things: ventricular, if they're regular, ventricular tachycardia, a supraventricular tachycardia with aberrancy. And aberrancy just means the electrical activity going through the ventricles are going at a slower than or abnormal irregular rate. And an accelerated intraventricular rhythm, meaning that there's no sinus rhythm and that the electrical activity is only coming from the ventricles. And then irregular wide, which could be something like atrial fibrillation with aberrancy, similar to supraventricular tachycardia with aberrancy, but it's irregular because it's atrial fibrillation with an associated WPW, or Torsade dependent, what we'll talk about. Okay, so two fast rhythms. So when I look at it, I'm going to say, is this regular or irregular? The QRS complexes come at the same regular rate, so it's regular. And then I'm going to decide, are the P waves consistent? So, and they are here, because you see, if you look in 2, you see a P wave before every QRS complex. And the best place to find P waves, because you can't always see them in all leads, are either in lead 2 or lead V1. Okay, so you're looking V1 or 2 for that P wave. And here you can see the P waves pretty good in 2, and they're consistent and they're there. So sinus tach, most common fast rhythm we're going to see. You want to treat the cause. You don't want to just slow it down, whether it's anemia, whether it's dehydration. You want to hydrate the patient. Pain, you want to adequately treat that. Drugs or toxins, fear, hypoxia, hypothyroid are just some examples of common causes of sinus tachycardia. So what is this? This is a fast rate. We see one atypical beat, which we'll ignore. This is a fast rate, right? It's narrow because the QRS complexes are very narrow. And they're pretty consistent. So it goes just about 150, a little slower. So if that's the case, there's only 3 choices. It could be sinus tach, it could be atrial flutter, or it could be SVT. Usually sinus tach tends to go in adults. Very rarely is it faster than 130, 140 for extended periods of time. Supraventricular tachycardias in normal healthy conduction systems are usually greater than 170. So whenever I see a heart rates between 140 and 160 and they're regular, the first thing I think about is atrial flutter with a 2-to-1 conduction. So there would be 2 P waves for every QRS complex, or you get a sawtooth pattern. So there's a P wave hidden here right after the QRS, and then another P wave here. So there's 2 P waves for every QRS, and this is a flutter with 2-to-1 conduction. Hopefully everybody can see those P waves. Sometimes one of the P waves can be buried in the QRS complex when it's going, well, in the T wave, excuse me, when it's going this fast. Okay, everybody can hopefully see that here. P wave, P wave, P wave, P wave, and this is the T wave, the end of it. So sometimes it could be buried. So it's 2 P waves for every QRS complex. So the atrial rate in flutter usually goes at 300, and the ventricular rate, depending on medicines, other conduction disease, usually goes no faster than 150. Okay, so next steps for that, you want to rate control them, watching out for low blood pressure or hypotension. And if they're unstable, you would want to rhythm control them, get them back into sinus rhythm, and that would be with cardioversion. Okay. So what's this? This is going at, remember that 1 box is 300, 2 boxes 150. So it's much faster than 150, closer to the 300. So this is in the probably 180 to 200 range. So this is a supraventricular tachycardia. Rates can be up to 300. Kids tend to have higher rates than adults. Adults usually you'll see it anywhere from 170, 180 to 210. You can sometimes see these retrograde P waves because it's going on the conduction system backwards sometimes, and you can see P waves going in the other direction. And you may have some ST depression, which is oftentimes because the heart rate isn't getting good blood supply. So the treatment for supraventricular tachycardia, you can use vagal maneuvers. You can use adenosine as the most common treatments if they're relatively stable, and otherwise we'd cardiovert them. Okay, I'm going to follow up EKG. Now let's go on to irregular narrow complex rhythms. So the three choices are atrial fibrillation, atrial flutter with variable conduction, or multifocal atrial tachycardia. So this is what you see: P waves before every QRS. But if you notice, the P waves look different, right? There's a P wave here that's inverted. There's a P wave here that's more sharp. There's a broad-based P wave here and a different sharp. So there's at least 4 different P wave complexes. So a P wave before every QRS, that's fast, something called multifocal atrial tachycardia. You want to see at least 3 different P waves, and you want to treat the cause, which is usually hypoxia in most cases. Classically, we'll see it in patients with COPD, but any cause of hypoxia could sometimes lead to multifocal atrial tachycardia. So what is this? This is irregular, right? So you see this is definitely longer than this. This is longer than this. So it's an irregular rhythm. The QRS is narrow. You really don't see good P waves of different morphologies. So this is not going to be multifocal atrial tachycardia. To be a flutter with variable conduction, you should see that sawtooth P wave pattern in the background. So this is going to be atrial fibrillation with a rapid ventricular response. You see no P waves, and I said you usually will run somewhere between 120 and 160 in most patients, unless they're on medicines to slow it down. So this is another example of atrial fibrillation. Treatment is rate control, again, similar to a flutter, and cardiovert if they're unstable. And these patients, if they're in it for a prolonged period of time, more than 48 hours, you should anticoagulate because the risk of clots can go up. And that depends on their risk factor, whether we use aspirin or the different anticoagulants, the novel anticoagulants or Coumadin. So let's go to wide complex tachycardias, okay? And ventricular tachycardia is the most common wide complex tachycardia we worry about. So you'll have a wide complex tachycardia with the QRS complexes being regular. And figuring it out can sometimes be difficult because you either lose your P waves or it's tough to see them. But if you see P waves and they're dissociated from the QRS, meaning they don't run simultaneous to, and you can see there's some buried P waves in here, the likelihood it's ventricular tachycardia. So when unsure, the dictum is treat it as if it's ventricular tachycardia. If it's irregular, we use different drugs. So you're looking to see if it's ventricular tachycardia versus SVT, and if it's unstable, you're just going to cardiovert it. There's going to usually oftentimes an absence of the bundle branch pattern. You should see a QRS that's positive, broad complexes, AV dissociation, or positive or negative concordance. The challenge with VTAC is all these things are not 100% except for AV dissociation, and you don't always able to see it. But if you see AV dissociation, it has to be VTAC. All these others I have seen with SVT with Aberrancy. So for VTAC, if they're stable, we use antiarrhythmics. If they're amiodarone and lidocaine are the most common drugs we use. If they're unstable, you cardiovert. If they're pulseless, then you would actually defibrillate. So again, as you guys are going, I assume throughout countries you use something similar, if not the ACLS algorithm. It's always, remember, if it's unstable, just shock. If it's stable and it's wide complex, greater than 120 milliseconds, then you, and they're stable and you're unsure, you can try adenosine, but then just go to the antiarrhythmics, amiodarone, procainamide, and typically lidocaine. They list sodiquil. If you're not sure if it's irregular, then you want to use procainamide as your first choice. This is an example of atrial fibrillation with WPW. Again, it's irregular, tough to see, but if you look, this P wave is consecutive, but then this one is longer. There's another one that's longer. So it's irregular and wide. Atrial fibrillation with WPW is what we're looking at here. The QRS complex morphology can change. So you can see this is sharp. This is a little more broad-based. This is a little broad-based too. This becomes a little sharper again. And it's easier to see here that they have different morphologies. So a fast, wide QRS complex greater than 120 seconds and irregular. Think atrial fibrillation with either aberrancy or WPW. This is an example that happens to be WPW. And I think I have a picture. The treatment for this, if it's unstable, you're going to shock or cardiovert. If it's stable, consider procainamide. So this is that same patient after the patient was converted back to normal rhythm. As you can see, it has what we call I can't think of the name of the wave. The delta wave, excuse me, the delta wave, which is a broad-based beginning to the QRS complex, which is classically found in WPW, or Wolff-Parkinson-White is the other name for it. Okay, here's a patient with tachycardia. It's fast. As you can see, it's irregular because it changes. And this is something called Torsade's DuPont, which is an irregular fast ventricular tachycardia. They call it, Torsade's DuPont is turning of the points. And what you usually see is a narrower to wider changes in the QRS irregularity. And this is a classic pattern right here in this small section. The most common cause of this is actually low magnesium. It can be treated with magnesium, even if it's not the primary cause. It's oftentimes followed by a prolonged QT. So first step, we treat with magnesium IV, then we cardiovert. If you can't, you can try overdrive pacing. Oftentimes, if you don't use magnesium first, cardioversion doesn't work, or they go right back into it. You got to be aware with Torsades because amiodarone, which we'd use in normal ventricular tachycardia, can actually cause it to be more refractory. So getting out of fast rhythms and ending with a few causes of ST abnormalities. We look for heart attacks as one of the most common things we look at when we look for EKGs, right? So we're looking for different types of heart attacks. And ST elevation MI is one of the most important ones because those need to be rapidly treated. So in the emergency department, or even if you're on the floor, if someone has chest pain, we do an EKG. One of the most common reasons we're doing it is to look for the cause. And you're looking at causes of ST elevation, okay? The most common cause of ST elevation that's treatable and dangerous is something called ST elevation MI, myocardial infarction or heart attack with ST elevation. Those patients are amenable to either TPA or going to the cardiac cath lab and getting an angioplasty or a balloon, oftentimes with a stent. Other causes of ST elevation, which can sometimes mimic it, is pericarditis, ventricular aneurysm. You can see something called early repolarization, or a left bundle branch block always has an ST elevation, and you want to look at that. So when we're looking at ST elevation in EKGs, some of the help can be your history, right? So sudden chest pain, oftentimes pressure-like, with radiation, whether it's to your jaw or to your shoulders, increase the risk of it being more likely ischemia or a heart attack. If it's more with changes in position or inspiration, it's more likely to be pericarditis. If it's asymptomatic following a heart attack, that's when you think about things like ventricular aneurysms. Early repolarization is an asymptomatic, just oftentimes seen in younger people. Rarely should you see it in patients over 50 who have diffuse ST elevation, which isn't associated with heart attacks. It's just a normal variant, and a left bundle branch block with a electrical conduction abnormalities, which if new can be a sign of a heart attack, but over the years, as people get conduction abnormalities, it's actually in patients over 70, it can be normal or seen in up to 30% of patients without having any active chest pain or other acute disease. So when we're looking at heart attacks, we're trying to determine if they have ST elevation, because those are the heart attacks that are improved if you take a patient to the catheterization lab for angioplasty, or if you give them TPA or another type of technoplace or another type of anticoagulation. So for patients, studies have shown if you can get the patient to the cath lab and balloon the diseased vessel within 90 minutes, the survival rate is better than if you give them TPA. In the United States, at least, if you have a site that does primary cath lab, our goal is to get them there with 90 minutes. Can be difficult if you have to transfer a patient, so we will go up to 120 minutes from the time of diagnosis to the time the balloon goes up in the heart. So how do you determine if someone has ST elevation? And we'll look at it on the EKGs. You're looking for new ST elevation at that J point we talked about earlier in 2 contiguous leads. And for men, if it's V2, V3, it should be greater than 2 millimeters, or women 1.5, but in any other leads, just greater than 1 millimeter or 1 small box in at least 2 leads that we call contiguous, meaning they're associated with the same areas of the body, increases your risk. So what do we talk about contiguous? Contiguous, we talk about laterally contiguous leads of 1, AVL, and V6. The inferior part of the heart is V2, V3, and AVF. And anterior part of the heart is V1, V2, V3. So going back, that's the main criteria we look for heart attacks. There are other things we talk about as heart attack equivalents. We used to consider a new left bundle as a heart attack equivalent, which in the right situation with a good description of chest pain is still considered an equivalent potentially, but isn't assumed if you see a left bundle to be a equivalent. So we talked about the inferior section. Right? The lateral part of the heart, or these leads, are considered contiguous, and then the anterior part. So when you're trying to differentiate between a heart attack and other things like early repolarization, usually we see reciprocal or other changes, meaning inverted T waves. The T waves are normally upright. Inverted or flipped T waves. The only area inverted T waves can be normal, or AVR and V1. And a posterior heart attack actually is the mirror image of an anterior heart attack in V1, V2, V3. We're going to see some pictures of those. So other criteria for heart attacks, for posterior heart attacks, you could see ST depression, which is the mirror image of ST elevation in the V leads, which is a big key. Okay, so this is an example of an inferior heart attack. You see that ST elevation, right? So the J point being right here, the end of the QRS complex, is above the baseline, which is actually considered from the T wave to the next P wave. So everybody sees this elevation in 3, there's elevation in AVF, and there's elevation inferiorly. So what I consider reciprocal changes is you get depression in 1 and AVL. So this is a sign of what I call opposite changes, or other ischemic changes. So this is an example of a lateral MI. As I said, you have the ST elevation compared to the baseline in 1 and AVL. Those are considered contiguous leads on the body. And again, those reciprocal changes or other ischemic changes in other leads make you consider this to be a real MI. If I saw ST elevation in all these leads, it would make me rethink it, because it means that the whole heart is ischemic, which is very uncommon. And this is an example of anterior ST elevation, which you see in V1, V2, V3. QRS complex ends, and the first thing you see is this big elevation. This is classically called the tombstone EKG. It's a high risk lesion because it's going across the whole anterior part of the heart. You also see some lateral ischemic changes, and then you have those reciprocal depressions in the inferior leads. So that's an example of an anterior ischemia. So this was a very 1 hour of usually each 20-minute section that I did is usually extended as you're learning over your careers. You can't teach someone everything about an EKG in 1 hour, but this was kind of an introduction to some of the things we look for when we're looking at EKGs in the emergency department or on the floors or in a cardiology office for signs of danger to patients. So in review, what did we look at? We looked at typically what the electrical activity of the heart means, each part of the heart, the P wave being the atrial electrical activity, the QRS complex being the ventricular depolarization activity. We talked about some of the slow heart rates, 1st degree blocks, 2nd degree blocks, 3rd degree blocks. Then we talked about some fast heart rates and how to differentiate them in a short period of time, whether it's regular or irregular, and whether it's narrow or wide. It breaks up to 4 different boxes. Each of those 4 different boxes, if you just remember the 3 choices that you have to think about. And then we think about abnormal EKGs, and I really just touched on other abnormalities like heart attacks, but there are a lot of other things we look at in EKGs. We look for electrolyte abnormalities. We look for signs of hypothermia sometimes. We look at other EKG signs of ST elevation that look like pericarditis. We didn't have time today to go into all those things. This was just an introduction to some of the most common things we look at and why in each different area of the EKG we look for different things. So with that, I tried to leave 5 minutes or so for questions.
Thank you, Dr. Silverman. So we are getting some questions in the chat box.
Sorry.
Yeah. So the first question that was posted, how can we spot MAS syndrome, EKG findings, and aortic aneurysms and myocarditis?
Okay, so for, what was the first one? I missed that.
MAS.
MAS. I'm not sure what MAS.
I don't know what that stands for.
If it's in a different language, it may be translated differently.
It might be. If some, Sammy, who
okay,
put
so,
the question, if you want to just
so
explain.
we could, let me go to the other 2. So pericarditis is much, you're looking for ST elevations being diffuse, but also you actually, the classic finding in pericarditis is PR depression. So classically the PR depression, and just let me flip back to a normal EKG. Classically, you'll see PR depression with the ST elevation, and the ST elevation is diffuse. The only place you should see ST depression in pericarditis is AVR. Every other lead should be either isoelectric or neutral or ST elevated. And invariably, it's most of the leads you'll see ST elevation. But the hallmark is the PR is oftentimes depressed. And the best place to look for PR depression is in lead 2 and lead 3, most commonly. And what was the third part of the question? I can't see the chat box.
So it's aortic aneurysms, myocarditis, and then
myocarditis. Okay,
yeah.
So myocarditis, again, there's no classic finding on EKG for myocarditis. You can see ST elevation that's not consistent, but it's more a diagnosis based on labs, elevated labs with signs of infection, so elevated either troponins or CPK-MB with signs of inflammation or infection is the way we diagnose myocarditis. We don't, well, the best way to diagnose this is a biopsy, which we don't do routinely, but the EKG findings of myocarditis are very non-specific. Aneurysms of not of the aneurysms of the heart, of the ventricle, you usually see big ST elevations in V2, V3. It's usually a finding post-MI, but aneurysms of the, if we're talking of the atrial vessels, again, not going to see it well on EKG. And the third thing, I don't know what MAS is.
It's Morgani-Adams-Stokes.
I'm gonna
I don't
leave that
know
out.
that
That's way.
syndrome very well.
Yeah.
It's not a very common, like, it's not something we're looking for
Yeah.
emergently to fix
No.
or, yeah. And can you discuss the EKG finding of J point elevation versus true ST elevation?
Yeah. So the difference with J point elevation versus ST elevation is those looking for those reciprocal changes for me is the best way to find it. J point elevation should be consistent across the limb leads, V1, V2, usually AVF, AVL, and the anterior V leads. So for classic J point elevation, which can be difficult, you shouldn't see signs of what I call reciprocal, or we call reciprocal changes, meaning signs of depression or inverted T's are the two things I look for to differentiate it. And it's gonna, J point elevation should be diffuse across all three areas of the myocardium. Not necessarily every lead, but at least one or two leads, both inferiorly, anteriorly, and laterally, because that's almost never going to be an MI unless you have diffuse global ischemia, which is usually see ST depressions more than elevations.
And I looked up this Adams-Stokes syndrome. So
Thank
that's pretty much syncope and a sudden loss of consciousness due to a pronounced decrease in cardiac output. It's just a paroxysmal shift in the mechanism of the heartbeat, but it's usually due to a AV block. So it's exactly what Dr. Silverman covered in the beginning. The type 2 and type 3 AV blocks are most common for those for that syndrome.
But not something we commonly think about in the emergency department.
No.
As an individual disease.
That's usually when they diagnose later, once we stabilize them. Any other questions, guys? Chat box is open. But wow, you put like 6 hours in an hour. That was pretty impressive.
Well, we probably got 2 hours worth of my stuff in the hour, but there's a lot more that we do. Yeah, well, usually when we do it, I like to do it as a challenge, but in this situation, it's very tough because there's so many of you, and by the time you type, we run out of time.
It's true, it's true. So. All right, well, if there's no further questions, we will just extend our break. We'll get a longer break this time. All right, so thanks, Silverman. Oh, hold on, you get one. Oh, can we get the advanced presentation later on? Oh, Silverman, I think they're inviting you back.
Actually,
6 hours
you can get a hour-and-a-half one if you join AAM this year, which has my extended version of board review. But certainly, there are a lot of good EKG programs out there. The other person, if you want to look for with EKG challenges, who's by far in emergency medicine, at least the EKG guru, any lecture by Mobitz II online is worth looking at.
Yeah, I do recommend his EKG weekly subscription. It's like $25 for the whole year, and he goes through real base cases on EKGs, and he's like the genius of EKGs. So
thanks, guys.
Yeah, thank you, Dr. Silverman. All right.
Oh, Mobitz II. Let me see. Hold on, can I do that? Let's see if I can do that.
I think it's oh, I missed the T. I was so close. Yeah, Chloe got it right.
Yeah, I think there might be 2 T's in his last name.
Yeah, it is. Yeah, the Chloe above me wrote it incorrectly. It's 2 T's, guys. So yeah. Awesome. Thank you so much.
So yeah, so if you guys are medical students, again, I don't want to push another practice, but I believe